The last of our TKIs are the tropomyosin receptor kinase inhibitors, entrectinib and larotrectinib. Biggest things that we are looking out for here is lymphocytopenia, hepatic dysfunction, and myalgias. Here we have one of my favorite graphics, which display all of the tyrosine kinase inhibitors with their associated potential adverse events. Next agents we have are the PARP inhibitors, or poly-ADP ribose polymerase inhibitors, which are used in ovarian cancer, breast cancer, pancreatic cancer, and newer data suggesting benefit in prostate cancer. The things we would be looking out for would be neutropenia, as well as extensive nausea, vomiting, and diarrhea. Getting into miscellaneous oral chemotherapy agents, so we have the immunomodulators of thalidomide, lenalidomide, and pomalidomide, which mainly are used in multiple myeloma. Biggest things which we are looking for is those thromboembolic events, as well as bone marrow suppression and hepatotoxicity. Should be mentioned that these agents can cause embryo-fetal toxicity, which you might remember if you are a Billy Joel "We Didn't Start the Fire" fan. Next agents up are the mTOR kinase inhibitors, everolimus and temsirolimus. Biggest things looking out for here is bone marrow suppression, as well as nephrotoxicity and infections. These two can cause wound healing complications, so holding prior to surgery as well as post-operatively. Then we have retinoic acid derivatives of tretinoin and bcrabl. So for bcrabl, looking out for new onset hypothyroidism as well as neutropenia and pancreatitis, and tretinoin looking out for that APL differentiation syndrome or leukocytosis and cardiovascular events. Now on to the histone deacetylase inhibitor of vorinostat. Biggest thing again we are looking out for is bone marrow suppression, so anemia, thrombocytopenia, neutropenia, and this is a QTc prolonging agent as well. Then we have the hedgehog pathway inhibitors, which have unique adverse events of muscle spasms and arthralgias. More often than not, the muscle spasms or arthralgia would not be causing a hospital admission, but it's just something to keep in mind. Moving on to our hormonal agents. Generally, they are safe to continue upon admission, as there are not many severe toxicities that would require admission themselves. First agents being the selective estrogen receptor modulators, tamoxifen, raloxifene, toremifene. Biggest reasons to hold would be if the patient is coming in with a thrombotic event, as well as if the patient has new onset liver dysfunction. Next agents, the aromatase inhibitors being anastrozole, letrozole, and exemestane. Reason to hold would be for thrombotic events. Antiandrogen therapy used in prostate cancer, abiraterone, apalutamide, bicalutamide, and enzalutamide, or abiraterone and bicalutamide looking out for new onset hepatotoxicity, and for apalutamide and enzalutamide looking out for new onset of seizures. One thing I would like to point out about the use of abiraterone is that it is used in combination with prednisone, and that is because abiraterone effectively depletes the body's cortisol, and through its feedback loop, it would actually try to increase the amount of ACTH as well as progesterone production, and then the increase in progesterone would lead to mineralocorticoid aldosterone-like effects, where we could see hypokalemia, hypertension, and fluid retention. By giving prednisone, we are essentially providing the body with the cortisol levels to prevent that feedback loop and prevent any of those mineralocorticoid aldosterone-like effects. One thing that I would like to mention is that there are some medications where we do have adherence consideration, where patients must be strictly adherent in order for them to get the most benefit out of the medication. This comes into play with chronic myelogenous leukemia and the bcrabl tyrosine kinase inhibitors. And so a study done by Jabor et al. Found that 44% of patients with rates of adherence of 90% or higher to imatinib, a bcrabl tyrosine kinase inhibitor, were able to achieve a complete molecular response, while 0% of patients with adherence below 90% saw the same results. That is because without chronic administration of the medication, point mutations were able to emerge on the ABL kinase domain of those genes. In this case, An adherence rate of 90% or above is imperative for better patient outcomes. So this is one of the situations where we would want to make sure that the patient is continued on therapy as long as these agents themselves are not the cause of their admission. And then again, here are the bcrabl tyrosine kinase inhibitors, as well as the reasons of why we would hold them. Lastly, other considerations to go along with oral chemotherapy would be supportive care agents. As we know, with parenteral chemotherapy, one of the biggest side effects is nausea and vomiting, and the same can be said for some of our oral chemotherapy agents. It's always good to review the emetic potential of the oral chemotherapy agent and seeing if patients need that accompanying antiemetic on board as well. That does it for this clinical pearl. Again, thank you for your time, and if there are any questions about this presentation, feel free to email me at sleeman1@monument.health. Thanks and have a great day.